You're ready now?
Yes, ma'am. Go ahead.
Great. Samsara, do you want to start with the introductions?
Yes, I want to welcome everybody to part 2 of the also thrilling and wonderful childbirth education series with Doula Mika. It's Doula Mika. I'm Doula Samsara. I am the executive director of the Oakland Better Birth Foundation. I am co-teaching, but really letting Mika teach. I might add some things in every once in a while. With great pleasure. Welcome everybody who's here, and welcome anybody who sees this recording in the future. And we'll talk more about the work of Oakland Better Birth Foundation at the end. Miss Mika, how are you?
Oh, I am doing well. Hold on, something. There we go. My name is Mika, and I am a doula and also assistant to Samsara Morgan and the Oakland Better Birth Foundation. And I am excited to be here and teaching this class for you all today.
Okay.
And, can just go around and briefly share your name and if you're a doula, student doula, parent joining us today, or soon to be parent. And we can let's see, Kathleen, can we start with you? You're next on my screen.
Okay. Certainly. Hi guys, I'm Kathleen. I am assistant to Samsara Morgan with the Oakland Better Birth Foundation and a part of Shifra's Circle. Continuing to always be a student and a birth worker. So happy to be here. Thanks, Mika.
Zaria?
Hi. Can you hear me?
Yes.
Okay, great. Yes, I'm a student doula. I've been with Shifra Circle all year. My name is Zaria. Yeah.
I'd like to go next.
Next, I'm Brooke. I'm also a student doula and a mom. This is Camille. He's sleeping right now. Maybe an early bedtime. Yeah, I'm also happy to be here in group with everyone.
Hi, I'm Jocelyn. I'm a doula with Shifra Circle and a BBF and childbirth educator. And I'm having technical difficulties, so I'm sorry if I disappear. And I didn't hear what the prompt was. Are we just saying hello?
Just saying hello. Yeah.
Okay.
Go next. I'm Julia. I'm a student doula with the Shifra Circle and also a doula in the real, I guess the other world. I've been doing it for about a year, so definitely still continuing to learn, but I really appreciate you guys putting this on and being here to continue to hear things and have information repeated so that it really sticks in my brain for the future.
Thank you.
Hi, everybody. My name's Anissa. I am a doula with Shifra Circle and a student of Samsara's, longtime student, always, and a child care enthusiast. Happy to be here. Thank you, Bo. Thank you, Mika.
Christina and then Priscilla.
Hi, I'm Christina. I am a doula and I am a student midwife. I'm happy to be here. I'm always learning new things, and it's nice to hear so many different people teaching the childbirth ed class, because everybody has a different style, and I really appreciated learning all the stuff I did last week. So I'm looking forward to what we're going to cover today.
Great. Priscilla, you're last.
Hi, I'm sorry. I'm like out and about. I'm on my way home soon, so I can't really talk much. Also, I forgot my mask, hence I have something over my mouth. I'm doing good. I'm just trying to get a quick bite at quickly with my sister-in-law. Hi, sister.
We're sharing like just your name and if you're a doula, student doula, parent.
Oh, okay. Sorry, I didn't know. Yeah.
My fault.
Hi, I'm Priscilla, and I'm a doula, and nice to be here with everybody.
Thank you. Great. All right, we'll go ahead and get started because last time we didn't exactly have time to finish everything. So we're going to start off with comfort measures.
Okay.
And we have a little bit more to cover this week than last week. So let's see how that goes. So I appreciate Samsara having a conversation with Samsara about even the language of comfort techniques or comfort measures, which another client of mine who's a doctor reminded me that comfort measures only is part of hospice care. Right. Mm-hmm.
That's powerful to remember.
That really what we're really talking about here is coping techniques and coping measures for labor. Labor is an experience that life hardly ever gives us, and there's a natural intensity to labor that people experience in many different ways. For some people, it's more intense than others for various reasons. But what we're talking, comfort techniques kind of is a misnomer that almost it might feel like you're going to a spa and having a massage, when really what we're talking about is coping with that intensity of this new experience. So, and I guess one thing I want to kind of go back to is earlier in the slides and last week, we talked about this, this fear, tension, pain cycle that some people can experience during labor. They become afraid of the contractions coming up, so they tense up, and then that tension is really kind of what causes a lot of pain. There's, our bodies are going to kind of do this thing as long as we're well fed, we're healthy, we're doing well. Our bodies are going to kind of do this thing called labor. And big piece of what we need to do is get our minds out of it. Because our minds cause that fear, which causes that tension and pain. And so if you think about one contraction, you build that tension, a little bit there, and then you aren't able to release or relax that between contractions. The next contraction, you're adding a little more, until you're just this ball of tension and experiencing pain. So what we're trying to do with our coping measures is A, kind of get your mind out of it, right? And B, relax you enough between contractions where you're not building that tension up, right? Penny Simpkin, who is one of the our wonderful doulas who's been doing this work, our elder doulas who've been doing this work for a very long time, and author of The Birth Partner, talks about what she's observed with people who have been able to kind of cope with labor really well. And she describes this as, she calls it the 3 R's. And the 3 R's stand for relaxation, rhythm, and ritual. So people in labor who are coping with labor well are instinctually doing these things. So many people will instinctually do these things, and it's nice to break it down and talk about it so that you have it as a tool in your toolbox, these 3 pieces. So rhythm can be movement, right? In labor, movement is a natural coping mechanism. It can also be your partner kind of rubbing your back in a rhythmic motion. It can be you just kind of swaying side to side. Rhythm can look a couple different ways, right? Relaxation. So we're always looking for relaxing through taking nice deep breaths and releasing our tension. Pregnant or laboring people tend to hold tension in their jaws and their shoulders. So as partners especially, but even as laboring people, remembering to relax the jaw, relax the shoulders. And we'll get into some other ways you can support relaxation in a minute. And ritual. Ritual I love because it can look like so many different things. It can be that thing that you do with every contraction. So maybe every contraction, you and your partner slow dance, right? Maybe every contraction, you lean over the bed while your doula gives you a double hip squeeze. Or maybe every contraction, you're looking at a focal point in the room, and that's grounding you. One of my clients at the end of last year, it was really wonderful to watch her. She was moving from active labor to transition, this very intense time of labor. She was hands and knees on the bed, facing towards the back of the bed. So she's in this nice upright position. She can move her hips side to side and get some rhythm there. And the diffuser, we had a diffuser going, and she could see the steam coming up from the diffuser. So with each contraction, she would breathe with the steam. So she had this rhythm of movement, but also the rhythm of her breath that was being supported by the steam from that diffuser. And that was her ritual. That was her ritual with each contraction, right? And the breathing, that kind of breathing, was relaxing for her. So that was one way where she came up with that kind of instinctually in the moment. Massage, of course, is one that's talked about often and is really wonderful because it does help you relax. The kind of like rhythmic massaging can be really nice. I mean, it's wonderful at any stage in labor. Early labor, the goal is to rest, right? Rest as much as possible, eat and hydrate. So that massage can really help the laboring person relax at that time. As you get more active in labor, sometimes what's really nice is to have that massage between contractions, because you might be tensing up a little bit during the contraction, and that massage can help remind you to relax certain parts of your body. It also brings oxygen to your muscles. And massage is one of those great things to practice early on before you're in labor, so that your support people know how to best massage you in a way that you like in particular. Something that's not mentioned in these slides that I think is important to know about is counter pressure. And counter pressure is also, I think, especially helpful in active labor and transition, and in many ways very helpful during if you have back labor. So that's baby's face is facing posterior or facing out, right? And that can really cause some pain in the back and lower back. So counter pressure could look kind of there's two common ways of doing it. One of them is taking the heel of your hand, and this would be the partner or the doula, the support person, and pressing that onto the sacrum or the lower back, the center of the lower back. And you do that during a contraction, and you just hold it in place. And the idea with counter pressure is this idea is called gate control theory. And the idea is that your body can only handle so much sensation at once. So like when you stub your toe, that instinct to go down and like kind of press your toe and hold it in place is gate control theory. Because when you stub your toe, you experience all this pain. But when you put your finger on there to add some pressure, you're replacing some of that pain sensation with non-painful pressure. So it takes the edge off. And that's what we can do in labor too. with counter pressure. So you take that edge off because your body, you're literally taking that pain away from what your nervous system can experience. You're taking the edge off. And then there's another style called a double hip squeeze. It is really hard to show the double hip squeeze like this without a partner on over Zoom, but there are a few really great videos. Essentially, you are, as a support person, squeezing the hips of your partner, and you're holding that again in place for the duration of the contraction. A lot of people love this. This is like, if there's like one coping measure you want to know aside from like massage, like the double hip squeeze will get you lots of points. And then another very simple kind of counter pressure that is nice, especially for people who don't really want to be massaged, don't really want to be touched much, is just squeezing their feet during a contraction. I do that like almost every labor, honestly. And it's something almost anyone can do. And it just feels really grounding for the person in labor when you feel like you could almost fly away, right? Like the intensity is so strong, you feel like, I'm just gonna fly. And having someone squeeze your feet during a contraction just helps you feel grounded, helps you feel secure and safe. It's really wonderful. We have in here. Any questions about those things that I just mentioned right now? And you can just go ahead and speak up because I can't see everyone on my little screen here without.
I don't have a question, but I think it's so funny because me and Priscilla had like a meeting before our recent client, and she was, you know what a double hip squeeze is? And I was like, no, I don't. And she was like, I can't explain it to you until we're in person. And she did it on the client and she was in love. She like loved it so much. So I just wanted to put that.
It's some wonderful stuff, let me tell you, from personal experience.
Let me offer something that might be helpful with the double hip squeeze. Mm-hmm. So a way to teach it when you can't be in the same room to show it is to imagine, say you have the client's bent over, say like that client right there. Mm-hmm. You're getting the massage. And imagine that she's got on a pair of jeans, and the back pockets of the jeans, on the outer corners of those pockets, you will place your hands and push in. Mm-hmm. If you're imagining like her pelvic bowl, here's the client's pelvis, little tiny little buddy. Okay, you're pushing up here on the top part, and you're literally pushing those bones in, and you're causing the bottom to flare open. And so it relieves a lot of pressure, and that's why it feels good to the laboring person generally. But if you imagine that you're looking at someone's beautiful rear end and they have a pair of jeans on, and where the pockets would fall, you're just on the outside rim of the pockets, squeezing in and holding firm while the contraction's going on. Is that helpful?
Yeah. And a lot of women also, like in their hips, they kind of have a dip in, right? It's like that's like kind of fleshy part. You're thinking that's the same place, that same place. Mm-hmm. Yeah. I feel like I need a pelvis. I need a pelvis. I need a pelvis.
I've just started calling it the butt squeeze because it's more honest.
It is more honest.
You're not actually squeezing the butt, though. You're not.
No, I mean, I still demonstrate, but it's at the butt cheek, not because I think people think of the side of the hip as like the exterior side of your hip, on like all the way to the left.
It's above the butt on that hip bone. It's literally it literally should be you're pushing in that top hip bone. But like a lot of things, if you're in the neighborhood and you're applying pressure and it feels good to the client, then whatever. But if you're just pushing her butt cheeks, that might annoy. I know that would annoy me if I was in labor.
Yeah, I guess it depends on the butt too.
Yeah, right. All right, so I would love someone to share with me just, or you can just even popcorn style some things that you notice that are similar about these positions here, these laboring positions.
Her knees are open.
Mm-hmm.
And there's somewhat of a squat. All of the, I mean, like the knees are open and bent.
Mm-hmm.
Mostly upright in the pelvis.
Yeah, these are really common positions that people naturally get into, right? It's some people call it the UFO, upright, over, and forward, I think is that she's doing in all three of these. And then here's really a supported version of that. But generally speaking, you want that nice wide open hip action going to give your baby space to make its turns as it comes down into your pelvis, right? It has to make its little turns to get down in there. And so having your hips nice and wide open, your knees bent, give you that space. And then you get to use gravity when you're in an upright position also to assist with baby coming down and coming down further. And, you know, there are also times when you just need to rest, and you got to listen to your body about that too. And so side lying, you can still have your hips wide open, which is nice and which is important. If, let's say, she did not have a pillow between her legs, it could actually make her pelvis a little bit smaller, right? And make it harder for baby to come down. Something actually I'll point out that is important in this position here is that her knees and her hips are in line. It's actually really important to protect your knees from damaging your knees in labor.
Is there?
Yeah, go ahead.
Yeah, that's one thing too, that when I was teaching they were like the first year nursing students, like the different laboring positions, was I had them actually like get in these positions so that they could feel the pressure on the knees, because
right.
I don't think people are always very mindful of that. So it's just like, how do you feel in this position? And like, how long do you think you could be in this position comfortably? So yeah, I think that's a really important point to bring up personally.
Thank you. Absolutely. Absolutely. And when you think of that additional weight from pregnancy and from having a baby in you, it's even more. Yeah.
Yeah. Mm-hmm.
And also there's a lot you can do on the bed, which is helpful, of not just laying in bed, right? Like you can use that cushion, that support of the cushion for your knees. What I like about this position here that they're showing is that the laboring person and her partner are facing each other and getting that eye contact. And that helps produce oxytocin, of course, right? That love hormone, that is what makes your uterus contracts. So she's in an optimal position for her baby by being her knees out. She's in kind of hands and knees. And she could sway side to side to get that movement, that rhythm going. And she also has her partner's eye contact that she has that will help move labor along as it helps her create more oxytocin and strong, powerful contractions. I know that when I was in labor with my first kid, I had whatever position I was in, I had to be able to see my partner's eyes the whole time. So both the squatting and lunging are great for getting that additional kind of wide open space. Squatting is also particularly great, like if your baby is up high, is kind of staying up high and bringing baby down a little bit lower. I really like how she's supported here with the stool. She could be supported with her partner, or she could be leaned, towards that bed right there. There's other ways of doing that. Lunging is also wonderful if your baby's posterior and you need to help turn baby.
Mm-hmm.
It's that, again, it's that wide open pelvis, and then that you would get do kind of a rocking motion, and it just really helps turn baby. And slow dancing, I feel like, is one that people instinctually get into all the time. It's another great oxytocin booster. You're close to your beloved, you're smelling them. It's really wonderful. And you're feeling super supported because you can just lean all of your weight and your energy into your partner. And you get that rocking motion, that rhythm. Your partner can massage your back to get relaxation. And the ritual might, maybe during that contraction, your partner's whispering something into your ear. That's part of that ritual.
We wanted to give a reminder about theta brainwaves. We do a lot of talking about oxytocin because it is our friend and we definitely want to create it. What also is happening in the brain is that we're encouraging clients to go into that place where people go in when they're in deep meditation, prayer, dancing, lovemaking. You go into that place where you lose track of space and time and you are just free and floating and open and feeling safe, feeling happy, warm and good. And that definitely helps labors to progress. It helps bond couple mates to each other even further. Helps baby feel safe to wiggle on down, right? Because the little baby gets afraid. If mommy's afraid, baby gets afraid. And then it won't want to wiggle itself down, come out into a scary place. You know, we forget that our newborns are sentient beings, right? So everybody's feeling all safe and lovey. It helps baby want to wiggle on down.
Absolutely. I feel like, when in doubt, hydrotherapy is the answer. When you feel like, I don't know what to do next, or if you're a partner, and you're feeling like, I don't know what to suggest next, just get in some water, it's another one of those very simple things to remember. Water. It really does help because, the uterus, I think I mentioned this the last time, a 9-month pregnant laboring uterus is the strongest muscle a human body can have. Super powerful. So it's a big, intense feeling for many people. We know that warm, wet heat, warm water helps relax muscles. And it can, again, be that thing that takes the edge off of the intensity while still allowing things to move. You still have the movement in your body. You can still be upright. There's so much that you can still do when you're in water. And it gives you that relaxed feeling that you were describing, some sort of like, oh, this is an environment where, I feel good. And so baby feels good. We're not stressed, and helps move things along.
Mm-hmm. It helps labor be so much more manageable, even if it is challenging. The two things can exist side by side. You can be challenged but feel safe. You know what's happening. You're not afraid of it. You're working with your body. You feel one with your partner. You feel one with the baby, and you just float all of you together on the experience of the labor.
Hydrotherapy is also, I find it to be very helpful during transition as well. Mm-hmm. That's one of those times where it seems like I'm recommending that more and more as a tool that's a time when I'm very commonly recommending that, because it is a time emotionally where you might feel like, I don't know if I can do this. This is a lot. Like, you might hit that emotional wall. And so if you think about it, like that time of heightened intensity around transition, what happens is right after you produce oxytocin, makes you contract. After every contraction, your body releases your own natural beta endorphins, which also increase with each contraction. And so at that height of transition and intensity in transition, if you're able to get into some water, to get past that last one of that feeling of like, I just don't know if I can do this, and you get past that moment, you get hit with this huge wave of beta endorphins. And then you can just kind of ride that wave to the end, ideally. And I've seen it happen so many times. This like, these really big feelings come up. We get in water, and then all of a sudden, it's kind of a little quiet, and it's kind of a little, I'm going there and I see mom just kind of like, all right, just like riding that wave. The birth ball, fitness ball, exercise ball, called many things. Definitely look for an exercise ball online and not a birth ball if you want to get the best price.
The exercise ball will be $35 and the birth ball will be $19.99.
It's, there are many wonderful uses for it. Definitely right now during the pandemic, you want to check in with your hospital beforehand to see if you will have access to a birth ball. Not all hospitals are keeping them on their floor. It's when you sit on a birth ball, and sitting on a birth ball is actually a good idea to do while you're still pregnant. It again helps create kind of this, opens your pelvis. It's like a supported squat. And so your baby can get in an optimal position for labor. We see this person forward leaning, which is really wonderful. And then there's a peanut ball, which is really helpful if you are resting. Like we saw that woman earlier with a bunch of pillows, especially in hospitals, they don't always have a bunch of pillows. Like there always seems to be a pillow shortage. I don't know, but enough pillows for you to really get that wide open pelvis. So a peanut ball is a good tool to use at that time. It's also very commonly used with people who have epidurals to keep their pelvis open because they don't have access to movement in the same way. So, traditionally in the US pushing, well, since birth has been in hospitals, I should say, has looked like women flat on their backs with their legs up in stirrups. We know that position actually makes the pelvis a little bit smaller and certainly much harder for pushing because your pelvis is smaller and you don't have access. You don't have gravity supporting you. So a lot of these positions here kind of show how you can use gravity to support you, and certainly having your hips wide open. So this is forward leaning. So she's on her knees and then she's leaning over the back of the hospital bed, which is propped upright. Can be really supportive and nice to have the back of that bed. And when you bear down, you kind of hold onto the bed and it really brings your energy down as you're bearing down. This woman is squatting and she's using the support of the squat bar, which most hospitals have. If you are interested in the squat bar, you might even want to add that onto your birth plan. Squatting again is great if your baby's up high. It can also sometimes make births happen very fast. And when they happen very fast, I was listening to a podcast with the midwife that said that actually was squatting for the actual birth of the baby can sometimes cause more tearing because it's so fast.
Exactly.
Whereas forward leaning, because you're leaning a little bit forward, you're taking pressure off the perineum, which causes less severe tearing. But certainly if your baby's up high, squatting while pushing if you need to for a little while, might be just the thing to bring baby down. And then you get into another position. It's also common to get into several different positions while you're pushing. Figure out, what works best in early pushing and then works better in later as you're pushing later on. Side lying and semi-sitting are very common in hospitals today. Those are the most common positions. If you are semi-sitting, you want to make sure that the bed is at least propped up some, so that you're using at least getting some gravity support for gravity. These are probably also more common with for people on epidurals, and that's what hospitals are used to seeing, right? Because you don't necessarily have as much sensation in your legs to try other positions. Is there anything else you'd like to add, Samsara, about pushing positions, or any questions?
No, well, I think the thing that's important to know around pushing, especially if you're birthing in a hospital situation, is that's a time of really high tension in the birth room. Hopefully you have a doula supporting you. Please have a doula, especially if you're birthing in a hospital. Have a doula whether you're birthing anywhere, but definitely in a hospital. The doula can kind of help keep the energy kind of nice and even keel. And know that it's important to not rush, like Mika was saying, like getting in that squat and just really barreling your baby out definitely will lead to tears and stress on the baby. But if you're following your own instincts, it's not romantic, but it is similar to the same function we use when we're pooping. So we don't want pushing too hard. We want to go with the urge to push. When you feel the urge to push is when you kind of bear down. And also know that if we are relaxed enough, it's not even so much about pushing. The body will eject the baby. Mm-hmm. So if we can relax enough to let the body eject the baby, that's even better for all concerned. Folks have a lot of concern about tearing. It's important to remember the people who really tear the most are the people on epidurals, because they cannot feel their little ones coming out of their bodies. So they push too hard and they barrel their baby through all that tissue and can cause some significant tears for themselves. So it's another reason to do your best to get the support that you need to be able to push your sweet baby out unmedicated.
Any other questions about comfort or coping measures? Because we're going to be moving on to medical procedures, but if there are any other questions, be happy to answer those. All right. So before we even talk about medical procedures, just plug in a few notes for self-advocacy. And one of those is creating a birth plan. I think it's a really good idea to have a birth plan. And a birth plan is not like a rigid document that can never change or something. A lot of people say, why would I have a birth plan when birth is unpredictable? Well, we plan for many things in our life. We plan, nothing that we plan for actually is necessarily going to go happen exactly as we planned it. But it gives us that guidepost. It allows us, when we create a birth plan, you are researching the benefits and risks of something. You are coming to an informed decision about what you're deciding. And in that process, I think it really is about that process of creating a birth plan where you get really informed. That is the benefit, because then you make choices. And if anything needs to change from that original plan, then you will likely have done the research to know where, when, and how you feel comfortable making a change on that birth plan. And then you can also add things like, I think like a good example is like, if you want to have an unmedicated birth, then you could say, please don't ask me for medication. Or for if I want pain medication, I'll let you know. So it's not being rigid necessarily about it, but it's putting the power on you and the onus on you to make that decision.
Also, the thing too is that hospitals go on autopilot. They have kind of a McDonald's menu that they're actually very rigid about. Yeah. And it's about protecting yourself from their rigidity. Yeah. To say, excuse me, this is me. I'm a different, unique human being. And I've done my research and these are my preferences unless there's emergency going on. This is what I would prefer to happen to me and my body and my baby in your facility. You have every right to do that. Your insurance money, your premiums are paying, your tax dollars are paying for your health care. You have every right to make those requests.
And that's also one reason why I recommend that you write your own birth plan. Like a lot of hospitals, they like, here's your birth plan and give you a checklist that you check off that are the things that they're okay with.
Right.
That's in their McDonald's plan, right? But that's not a real birth plan, right? A real birth plan is something that you create on your own outside of the structure that the hospital has provided with you, because those are just the things that they are okay with. It's not necessarily all the options that you have available to you.
Yeah, can I is it okay if I just
Yeah.
Yeah, definitely. When I was on rotation at the hospital I was at, they had like their like McDonald's birth plan.
Mhm.
And one of the things that I would always ask the patients I was working with that was not on there was, how many students, or do you even want students at all to attend your birth? Which
Right.
surprisingly or not surprisingly was not a question, because it's a teaching hospital. They just assume.
Right, there you go.
Yeah. And one of the patients I worked with was like, no, I don't want anybody who's a student at my birth. And so I was like, okay. And I hand wrote that in, and I mean, hopefully they respected her wishes, but that was definitely something that was not on there.
Mm-hmm.
Yeah.
And you got to be careful in some of the hospitals, though, when you say that the hospitals have tied the doctors being taught to the midwives. So if you want to be birthed by a midwife, you have to allow the student in the room. Now, I think that, clients can push back on that, but it's important to know that you might be automatically denying yourself a midwife by that choice, and then having to advocate again to say, listen, I'm, sorry there, junior baby doctor, but I just want a midwife and I just want to give birth in the hospital, and to advocate for that, or have your doula or partner speak for you on that if you can.
BRAIN is a great acronym to remember some of these pieces around self-advocacy. It stands for the benefits. What are the benefits of what's being suggested? And we're talking about medical procedures and interventions here. What are the risks? Are there any alternatives? What does your intuition say? Your baby's inside of you. Your intuition is particularly heightened at this time, right? And what if you said no, or not now? What would happen? Sometimes it seems like a doctor really wants you to do something. Let's say they come in and say, now it's time to break your bag of waters. And you can say, well, what if we don't do it now? Or what if I say no? And they're like, oh, okay, that's fine. I just like to do it because it moves things along fast. So there's a lot of times things are presented as something that this is the time that we just do this thing, or this is a part of our standard protocol, but it doesn't mean that it means that it's necessary. It's particularly necessary, let's say, or that it has to do with saving a life, let's say, right? This is just, that checklist of things that they do. Any additions to BRAIN this time? So we're seeing a lot of inductions now, and inductions are generally on the rise in the country, and particularly during this pandemic. Let's say traditionally, there are these kind of three main reasons why inductions have been offered, and we have a third one that's becoming, our fourth one that's becoming more popular now. But pregnancy continues too far past the due date, and that in the US, that means 42 weeks, generally speaking. Some people's families, their families go into labor past 42 weeks, and that's just like how their bodies roll, how their family's bodies are. And that's, there's nothing wrong with that. But in the US, we have a legal requirement that says that birth cannot go past 42 weeks. The health of mom.
I wanted to say that's only in California.
Oh, really? I thought it was the whole US.
It's not national, it's regional. And so, and even in California, some hospitals are not as rigid about it as other hospitals. So you want to check with that, but it's not national, it's California.
I know that.
Yeah.
I know that. Cool.
Doesn't mean it won't try to induce you anyway.
Yeah. Another reason is if the health of mom or baby is at risk, if pregnancy continues. We talked a little bit about, hold on here. Sorry about that. Like preeclampsia is a condition, intrauterine growth restriction are times when induction might be considered. And if the bag of water breaks and contractions don't start, typically in US hospitals, if that happens, and let's say your bag of water breaks, but contractions haven't started, and you call the hospital, they're going to want you to come in right away for an induction because they want you to have your baby within 24 hours, whereas your body will likely go into labor within 24 hours, right? And so there's a big discrepancy and difference there. The concern there is infection, but infection is more common with internal exams. And where do those internal exams happen? In the hospital. And they often do, I've seen many times, an internal exam to see if your bag of water has broken, right? And the way that they first monitor to see if you're at risk for an infection is by taking your temperature and seeing if your temperature increases. So here it says if the cervix is ripe, induction is usually more successful. So there is something called the Bishop score, which is based on the softness of the effacement. If there's any dilation, that lets us know if the cervix is more likely to, if an induction is more likely to be successful, but that usually means because labor is probably just going to start soon. We'll get into we will get into all of the methods of induction, but this is just the reasons. Oh, and the fourth that I was going to mention too is recently a study was done called the ARRIVE trial that looked at 39-week inductions and with a sample population, and the conclusion of that study was that elective induction at 39 weeks led to lower C-section rates. Because of that study, very recently, ACOG has said 39-week inductions are okay to offer to your clients. And so we're seeing a huge increase in inductions. There are a lot of issues that many people have brought up around that study. A big one is just this, they didn't do any analysis of the satisfaction of the laboring people. So what were their emotional outcomes, of that study? There are also a lot of other methods that lower the rate of C-sections, including having a doula, using movement, having an unmedicated birth. Right. Oops. So augmenting labor is different from inducing. Augmenting labor is when you use medications or interventions to speed up labor. So maybe labor has stalled or slowed. They're usually a part of induction, but labor augmentation might even happen outside of an induction. And it definitely should only be done if medically necessary, because there are risks involved. And we have a great note here. If your labor slows down, try walking and using upright positions to help strengthen contractions, right? And this can be done when you don't have pain medications. So, sorry, I'm just trying to get this. Okay. So there are a few different ways that are very common within the, obstetrics to induce labor. There are ways outside of obstetrics that midwives would recommend, that other healthcare practitioners like acupuncturists might recommend. But for obstetrics, there are a few different ways. One of them is stripping the membranes, which is, let's say this is your cervix. The doctor would stick a finger into your cervix. You would need to be a little dilated, maybe a centimeter or so, and they would swipe their finger around the outside of the bag of waters to kind of release some of the kind of membranes that attach to the side of the cervix. And then the idea of that is that stimulates your body to produce prostaglandins, which soften your cervix and cause you to contract. This can be done in your doctor's office. Sometimes when you have let's say your 39-week appointment with your doctor and they do a vaginal exam, they might even strip your membranes without asking you.
Mm-hmm.
So that's something to ask about. It can also be done in the hospital. The concern with stripping the membranes, it sounds very benign, right? Like there's no medication involved. You don't have to be in a hospital, admitted into the hospital. It just happens in the doctor's office. But there are a few concerns around that. And one of the big ones is just that it can have you contracting when your body really isn't ready to go into labor. So it can cause you to get really exhausted from these contractions that aren't really causing or supporting effacement and dilation. In rare circumstances, but certainly can happen, is that the doctor can accidentally break the bag of waters. Is there anything else you'd like to add to stripping the membranes?
I think that the most important thing about stripping the membranes is that it is a form of induction. It feels like it's not, because you're just doing something with your hand, but you are physically altering the body. You are creating a chemical release in the body that the body didn't do on its own. And the labor is this very precise cocktail of hormones and muscle reactions and brain reactions. And if we interfere with that, we interfere with the whole dynamic of what birth is supposed to be.
Yep.
And it may not go the way we want it to, because it was designed the way whoever put it together, whether you believe that's God or evolution or however we think about that. When we're going against that process, troubles come. So folks are worried about, it's folks who really, I've many clients who say to me, I really don't want a C-section, I really don't want a C-section. Then it's really important to do your best to, of course, barring medical need, like if there's something wrong, if you, baby, are sick, very high blood pressures and issues like that, or a baby, 42-week baby, like almost nobody gets to be pregnant that long anymore. But say you were, that might be a different thing. But overall, it is best to let the body do this on its own clock.
Mm-hmm. Yeah, and there's always, there are always times when interventions are needed, right? There are times for interventions, for induction, for augmentation. It's just there's an overuse of that in this country. It's not always used when medically necessary.
Right.
A cervical ripening agent, the idea behind those is that they soften the cervix if the cervix is still firm. And because right, what we talked about last week, your cervix needs to soften and thin so it can dilate fully to 10 centimeters. So two of the main kinds of cervical ripening agents we have that are used in this country. One is called Cervidil, which is a gel that's in a tampon-like device that's inserted into the vagina, and it causes the cervix to thin. It's a synthetic form of prostaglandin, which is the hormone that does that naturally in your body. Another form of cervical ripening agent, which is actually the picture that's here, is a pill called Cytotec or misoprostol. In hospitals, at least in the Bay Area, they often call it miso for short. It's so interesting working with clients all over the country because there are many places where they still call it Cytotec, but it seems like in the Bay Area, they call it misoprostol or miso. In this picture, you can see that it's in, it's like a half of a pill, right? So misoprostol is an ulcer medication, and it's not FDA approved for labor induction or for use in labor or pregnancy at all, but it's used in every hospital in this country and around the world. And it's used because it's very cheap and it will create very strong contractions. The problem with that is sometimes those contractions are too strong. And so it has led to some very serious issues, including like hemorrhaging, uterine rupture, and in some very rare and tragic cases that has led to infant and maternal mortality. So there needs to be a lot of discernment around the use of this. One of the issues we face in Bay Area hospitals is that when it comes to cervical ripening agents, there are many hospitals that only have misoprostol available. It is also, because it's not FDA approved for labor, what needs to happen is that the dosage of the pill, one full pill, tends to be more than what is more than what is used as a protocol in labor. So it's cut, right? It's cut by the nurses, and you hope that that cut is precise, but it's not going to be as precise as, let's say, if it was medication designed for labor that was in dosages made for labor, right? It's also used in different formats. Some in the Bay Area, in recent years, it's mostly given orally, but there's still many places in the country that insert it vaginally directly onto the cervix. So they're kind of experimenting with how to use this still and what dosages to give. Because it is a pill and let's say not an IV medication, once it's in your system, it's in your system. And if you are one of those people that has a bad reaction to it, you kind of need to let it do its thing until it's out of your system, right? Whereas at least with an IV medication, they can pull the IV out and it's out of your bloodstream fairly quickly. And then here we have a Foley catheter. So interestingly enough, the images as they're on the screen are often how people are induced. First, they're offered a stripping of the membranes, see how that goes. If their cervix is still firm, or the doctor's like, let's just kind of get things moving along because misoprostol does cause very strong contractions. They might then go with a cervical ripening agent. And then they'd move along to a Foley catheter. A Foley catheter does need to be used on a cervix that's slightly dilated and effaced because it's a catheter that's inserted into the cervix. It has a balloon at the top. I believe, really, this is a picture of a Cook's catheter, and a Foley bulb would have just a bulb at the top, but this is a Cook's catheter at either end. And those balloons are filled with sterile water. And the idea is that the pressure from those balloons will cause you to dilate to about 3 centimeters or so. It's
3 or 4.
3 or 4. It's often, let's say you go in for your induction, it looks like your body's ready for a Foley catheter. They might place it at 10 o'clock at night and expect that it will fall out because you're 3 or 4 centimeters at about 10 o'clock in the morning. With a Foley catheter, I mean, one of the big benefits is that it's not a medication, so you don't have to worry about the side effects of like a pill or a gel or something like that. It is definitely uncomfortable, the insertion, and there is still that, similar to stripping the membranes, that risk of breaking the bag of water. It's usually done. Well, until recently, it's mostly been done as like inpatient in the hospital. We are seeing more, at least in the Bay Area, that it's being offered as something that they might put in the hospital and then send you home. So these are both offered as inductions or augmentation. And the first one is an amniotomy, which is a manual breaking of the bag of waters. And what it is the doctor would use, or midwife would use, a long crochet hook like device to go in and literally break the bag of water. Excuse me. The idea behind that is that when your bag of water breaks naturally, you release this huge gush of hormones, and that can kind of help propel and move things forward in labor. The pressure of the baby's head on your cervix, right? You don't no longer have that push of water on your cervix, also will help you dilate. Of course, when you break the bag of waters, you increase your risk of infection. It's also ideal for your bag of waters can just stay intact until you're pushing or until the very end of labor, and you get that, it breaks, and then you get that last burst of energy to push and have your baby. And that's a really wonderful, ideal time to have this happen. When you have that too early on, you get this kind of burst of energy, and sometimes can even cause the shakes, and it can cause this adrenaline rush. And then it kind of fizzles out, and you no longer have that to propel you forward. And then that cushion that you had from your bag of waters being intact is no longer there. So the intensity of the contractions can also be a lot stronger. And then last we have Pitocin, which I think most people are familiar with because it's been around a long time, and it's been given to most women who labor in U.S. hospitals have had Pitocin. Pitocin's an IV medication, and it can be used for induction. It's often used for augmentation. It is a synthetic form of oxytocin. So it doesn't like give you the feel-good feelings. It's not working like that. But really what it does is it goes to your oxytocin receptor sites and responds to those and causing your uterus to contract. It can also fry those oxytocin receptor sites, which is one reason. And so if you have a high dosage, let's say of Pitocin, it could fry those oxytocin receptor sites. Those receptor sites need to heal. And it's one reason why Pitocin, there's a higher risk of postpartum depression with Pitocin use, because your body literally can't process the oxytocin that it could before and needs to heal.
Such an important point, because so many women do get Pitocin. So many birthing people are offered it, and then the depression is then taken into a psychological construct, and then you're being given medication for the fact that the Pitocin fried your oxytocin receptor sites. You can't feel as happy, and you're wondering why I don't feel happy as I did before. And they're not told that will heal. Or go get some acupuncture, right? Right? And that will heal. Your body will restore itself. It's a side effect of the medication. No one's told that. But if you're starting to feel you're sad, you're crying, you're wondering why you can't enjoy life like you did before.
Yep.
Here, we're going to give you a medication, more medication with deeper side effects that have a lifetime stigma attached to them. Unless, of course, when people really need their antidepressant medications, God bless. But this was caused by the Pitocin.
Yeah.
Right.
And it's also another reason why sometimes there's a delay in your milk coming in, because you also need those oxytocin receptor sites. Right?
Justin's going to teach us all about oxytocin next week, right? Is that next week? Yay.
Yay. Pitocin is usually given, they usually start off with small doses and work their way up. And the goal is for, in obstetrics, is to get your contractions closer together. So ideally 2-3 minutes apart, longer and stronger. And so they'll dose you until you get to that place for your labor. Something that Pitocin is also given prophylactically during the after the birth of the placenta to rapidly contract your uterus, and it'll be given to you. You won't even know. You might have a totally unmedicated birth. You might say that you don't want any Pitocin, that you want to have an unmedicated birth, and they will still give you Pitocin unless you specifically say in your birth plan that you do not want Pitocin postpartum or after the birth of your placenta. And even then, they might give it to you. And we talked a little bit about that.
You're right, Jessalyn.
I cannot see any of your chat notes right now.
No, don't worry about it. It was not. We were talking in class, teacher. Sorry.
Oh, it's okay. Anything else that feels pressing that needs to be added to this forms of induction and augmentation? I've been really, like, during this shelter in place, it's very interesting. I've been hearing a lot of doctors reverting back to this very old idea, like that you want to have a smaller baby, that smaller babies are here to be born. I've heard this from multiple doctors in the Bay Area, clients with their doctors.
Very frightening.
And that is not a evidence-based stance, period. You know, I've heard doctors say, well, you don't want to gain more weight, do you? What you want is to have again, labor and pregnancy and birth is an experience that life hardly ever gives you, and you can have a beautiful, transcending, challenging experience. Why not go for it, right?
It's actually easy to deliver a bigger, vibrant child than a small, sickly one.
Yeah, right.
You know, and all little ones lose some weight right after they're born. All little ones lose a little bit of weight, which is not really their weight. It's like water, because they've been pickled in water for 9 months. So if you have a nice 8-pound baby, it can lose a few ounces and not be in a crisis zone, right? Mm-hmm. If you have a 5-pound and change baby or a 6-pound baby and it loses a few ounces, that baby could be pushed into preemie status. Mm-hmm. You know, so you want to have a vibrant kid, all the nice, rich, healthy fat cells with nice little rolls that we want to see in little newborns that help them to have stores, to be able to have time to learn how to breastfeed without losing a bunch of weight, you know, and just be a healthy, vibrant little human from the very start.
That reminds me that, yeah, another reason why people are often encouraged to induce is the baby size. There's concern about the baby size from an ultrasound, right? Baby's too small, baby's too large. What we know about ultrasounds is that after the 20th week anatomy scan is that their accuracy rate goes down significantly. And so you cannot rely accurately on an ultrasound at 37, 38, 39 weeks to tell you if your baby is too big or too small.
Yeah.
External, so we'll move along. I'm taking a look at this time here. External fetal monitoring is very common, and this is used both in non-stress tests. When you go to triage, it will be one of the first things that will they'll want to do is to monitor your baby, and what they're monitoring is the your baby's heart rate and your contraction pattern. So if you look at this mama right here, the bottom strap, there's just like a little paddle, I guess that's what I call it here, and that's monitoring the baby's heart rate. So if you think about it, baby's head down, the heart is a little bit lower. And then the top paddle is monitoring her contraction pattern. And then that monitor is attached to a little computer machine here, I should say, which reads out the contraction pattern heart rate. So this is the heart rate here, and this looks like the contraction pattern. It also read out on a computer screen. And a pro tip here is that this can be really bright at night if you're trying to sleep and you're at the hospital. You can turn that off. You turn that monitor screen off, they can still see, you know, you're not turning off the whole machine. If you'd like to get up and walk around and move around, they'll have a like a wireless device that you could plug this machine into that allows you to move around more freely. What's not mentioned here is internal fetal monitoring. Oh, I guess I should say actually, before I move along, external fetal monitoring, usually they'll want to do like get a 20-minute strip, and then you can be off the monitor for a couple hours, let's say, and then they'll want to get another 20-minute strip. That's called intermittent monitoring, and you can ask for that in your birth plan. If you, though, are on any medications like Pitocin or Cervidil or any of those, you will need to have continuous fetal monitoring to make sure that you and your baby are responding okay to the medication. So what's not mentioned here is internal fetal monitoring. Internal fetal monitoring is a little bit more of an invasive form of monitoring. There's a catheter that can be inserted to monitor the strength into your cervix, to monitor the strength of your contractions. And then there's an electrode that the little screw at the end, and it's screwed into the fleshy part of the top of your baby's head. So not into the bone, but the fleshy part. And then that monitors your baby's heart rate. And as you can imagine, that is not comfortable for your baby. It's an owie.
Yeah.
This is often offered when your baby's really low in your pelvis and like around pushing time. One of the reasons why is that your pelvis bones are pretty thick, and it can be harder to get a good read of your baby's heart rate from the external monitor at that point. You would have to like hold the monitor in place. So then, because your doctors want to have a clear strip, the strip that shows the heart rate and the contraction pattern for liability purposes, so not necessarily for health reasons, but for liability reasons, they're gonna offer you that. Something that you can do, especially as doulas, as partners as well, I'll often say, would it be helpful if I hold the monitor in place and find the heart rate? And I've had many nurses say, oh, I can do that because it's like their job really to do that, right? But they're like, oh, I don't really want to do that, but I guess I have to do it. Or they'll say, yeah, thank you. That would be really helpful. And you can do that.
Yeah.
Usually you can avoid it by just holding it in place and finding the heart rate. This is something that really, go ahead.
Big concern is having that strip showing the baby's exiting its birthing parent's body.
Yeah.
So if there's any concern or confusion or litigation, they want to be able to show the baby was in good shape coming out. That doesn't mean that there's anything actually physically wrong with the baby.
Right.
And so if it's simply a matter of somebody holding onto the paddle so that they get that good strip, why potentially, I mean, you're poking this baby with a sharp little piece of wire, it hurts. Why do that and impede and shut down? And again, the baby's a sentient being, the baby's alive. It's a little furry critter. Imagine a little kitty or a little bunny, right? You hurt it, it shuts down. And you don't want the little human shut down when it needs to be helping the mother's body to push it out, right? And we don't want to unnecessarily injure this little baby. It hurts. Yeah. Of course, if it was a true emergency and we're trying to save a life, we do whatever and then we try to repair afterwards. But this is not a true emergency.
In terms of pain medications that are offered, there are other pain medications other than epidural that are offered in the hospital that are important to know about. One of them is laughing gas that's offered. It is not the same strength as what you might get in a doctor's office, but it's there nonetheless. I've seen some hospitals have actually restricted that use during shelter in place, are not allowing it, or during the pandemic, I guess I should say. Yeah. Laughing gas, it's not actually a pain medication. I think that's important to know. It is, it's the goal of it is to make you feel high and like you just don't care. And so some people get it thinking that it's going to relieve them in some way, and it doesn't. It also does cross to the placenta. It metabolizes quickly in your lungs. So usually you puff, you inhale during a contraction, then you take it off. But it does cross the placenta. I have personally, I've only had a few clients use it, but no one's ever actually enjoyed it. Like you have to learn how to inhale properly, and then it doesn't really do much. And most people I've had use it just kind of like, oh my goodness, like this is annoying. Get rid of this thing.
They either do that or get irritated because they're trying to get out of the pain. So while they're trying to get out of their discomfort, they are then not making their own natural oxytocin and endorphins because they're focused on trying to get out of it. And then it's like, I need an epidural now. Just give me an epidural.
Yeah, I was gonna say, yeah, it's like it's a gateway drug. In the labor room, for sure. Other forms of analgesic, really in Bay Area hospitals and most hospitals actually in the country, what's offered are IV pain medications, and fentanyl and morphine are the two most commonly used, especially fentanyl. And you might hear, like, if you come in and you're kind of tired and you say, I don't want an epidural, I don't want an epidural. So, well, let me just give you something. You'll just take a nap. It'll take the edge off, right? See, right here, take the edge off. This is what the nurses say. So then you get that IV fentanyl. You get kind of loopy and high again, and you really are, but that's a lot stronger than laughing gas. But what happens when you are taking an opioid is that it kind of rushes your system with endorphins, right? So your body stops producing its own natural endorphins. And when that medication wears off, all of a sudden your body hasn't been making its own natural endorphins. And after that next contraction comes, you feel it way more intensely, way different than you would have otherwise. And the vast majority of people at that point are saying, give me the epidural. So a few pieces about that. The advantage is, yeah, it can be given soon after requested. A nurse can give it to you. You do not need an anesthesiologist. They will get it for you like that if you want it. And it works fast. And it does not numb your body, so you can still move around, but they tend to want you in bed still.
Yeah, they won't let you up.
Yeah, so you can move around in bed. It does not, it's about that, like making you high more than, let's say, pain relief, like numbness. It's not numbing you. It can definitely make you feel drowsy, disoriented, itching, nausea. And because it's an opioid, it can slow down your breathing or lower your blood pressure. And because it's an IV medication, what you take in, your baby is getting, right? Because it goes through your bloodstream and crosses the placenta to the baby. So it can make your baby sleepy and less alert at birth and cause difficulties with breastfeeding at first. It can slow down your baby's breathing and reflexes. Now, it is suggested that it's best to avoid opioids right before birth, but birth is unpredictable. And, they want to limit, it's a controlled substance, so they want to limit the number of dosages you can get. But I've seen them offer it many times at transition, not realizing that a client was in transition and realizing that if that baby had gotten that intensive a dose of fentanyl, it could have been very serious. And so they can't really predict when that baby is going to be born. So it can cause more issues and concern at birth. Something else is that just like an important to know, and a pro tip is that sometimes when they're giving an epidural, the anesthesiologist will say, it takes about 15 minutes or so for it to kick in. Do you want me to give you something to take the edge off now before the epidural kicks in? Mm. And so some people say, I don't want to have IV pain medications because of the serious risk and concern to baby. So they go for the epidural, not realizing they're giving you that IV fentanyl to take the edge off while your epidural kicks in. And we'll talk a little bit about what's in an epidural, but that is, I think, really important to know because I have also seen that happen. I tend to see morphine more often earlier on in labor. Like they will offer, like if you go to the hospital and you're 1 or 2 centimeters dilated, but you haven't slept all night, they might say, hey, why don't you have this shot of morphine and go home and sleep? Depending on how your body responds to that, maybe you'll go home and knock out and wake up. Maybe you'll go home and throw up all night. Mm. There's all different responses that bodies have to these medications. Maybe it doesn't wear off in the way you need it to wear off ever, right? And you're just really high for the majority of your labor, and that feels disorienting. Epidurals are, you do need an anesthesiologist or a nurse anesthetist for an epidural. And it does actually numb the sensations in the uterus, abdomen, and lower back. It is a combination of a numbing agent like lidocaine and an opioid like fentanyl or morphine. So that is still a component of an epidural. different anesthesiologists kind of have their different combos and percentages and how that looks, what they use. But those are generally the two components. People often do feel pressure depending on how strong the epidural is. It takes about 15 minutes for it to be administered, and we'll talk a little bit more about what that looks like. So with an epidural, they'll usually ask the person to either sit at the edge of the bed or lie down on their side and curl their back over to create more space between the spinal columns. The birthing person is given usually a shot of lidocaine, numbing agent, first, and then the needle is inserted. It's a hollow needle. It's inserted between the spinal columns, and then a catheter is threaded through that needle into the epidural space, which is that fluid right outside of the spinal cord. Then the needle is removed. The catheter is taped in place for a continual flow of medication. Epidurals are very effective in that they numb you, right? And a good use of an epidural is you've been in labor for several days and you are exhausted and you need to sleep. And the difference can be, you know, between pushing your baby out and having a C-section, for sure. There are times when this is definitely needed. It doesn't affect the mom's state in the same way that IV meds affect them, but most women, when they get an epidural, the first thing they're going to do is take a nap because they've had some opioids. Mm-hmm. It may offer, there are several risks. It may offer incomplete relief in all areas. I hear this actually very commonly, like you might feel relief on one side, but not on the other. It can lower your blood pressure, and which can cause the fetal heart rate to drop. You are supposed to be given a bolus of fluids before an epidural to help prevent that, but that doesn't always happen. So that is something, especially as a doula, to be aware of if your client is going to get an epidural. It can cause shivering, fevers, itching, nausea. If you have a fever, it is not going to be considered a side effect of an epidural. It's going to be treated as an infection. And so you have more interventions that are going to come into play then. Can definitely cause soreness, bruising at this administration site. And for some people, it causes headaches, backaches for much longer after the birth. You definitely have to have continual fetal monitoring with an epidural. You will need to stay in bed and have a urinary catheter because it tends to relax the muscles so much, it can slow labor down, and then you're now introducing Pitocin, and you're going down this medical cascade of interventions. It may also decrease mom's ability to push effectively because you can't feel in the same way, and you may also decide that if you were unmedicated and you're pushing and it feels really intense, you might kind of slow down and back up a little bit and then delicately start pushing again. With an epidural, you don't necessarily have that sensation to work with. Also, it's not listed here, but it's common for certainly most hospitals in the Bay Area and many hospitals around the country, is that once you're on an epidural, that they won't allow you to eat solid food any longer. You can only be on clear liquids. And if you're getting an epidural early on in particular, you could be really, laboring, you use a lot of energy when you're in labor, and getting hungry, getting to that state where you're hungry can also impact baby's heart rate, can impact your energy that you have to push, can impact the energy that your uterus has to contract. What I like on this epidural page is you most certainly, if you plan on getting an epidural, will want to wait until you have a regular contraction pattern. Definitely rotating side to side in the bed to mimic some motion. You can allow baby's head to come down a little bit more. So if you're fully dilated, wait a little while until baby moves down the pelvis a little bit more to conserve some of your energy. And also, of course, as our nurse here reminds us, that there are non-medical pain management techniques that we just talked about that you can use. Second stage interventions are used to assist the baby through the birth canal. If for some reason mom can't push effectively, it might be because of an epidural, it might be because of exhaustion, it might be because of position if you're laying flat on your back, let's say. And it's also used if baby needs to be born quickly, like there's noticing a drop in the heart rate, that's really concerning. If these interventions are being recommended, and you're able to, it's a good idea, and you're not upright already, to try upright positions, and as doulas to recommend that and support our clients with that. Forceps and vacuum are two of these methods, I guess I should say. Forceps were kind of traditionally used in standard practice in the US. They're less common now. The vacuum is more common. With forceps, they're placed on each side of the baby's head. As mom pushes, baby's guided out with the forceps. A vacuum is probably more commonly used now. It's placed on the top of baby's head. There's a vacuum source that the doctor is in control of. And as mom pushes, doctor pulls baby's head.
It's important to know that all that pulling, it's very hard on the baby's head. It's not a gentle process, either one of those. In the olden days, some doctors were very skilled with the forceps and they were able to use a lot less pressure. Nowadays, because so many doctors haven't been trained how to do it, or they do it so rarely, they don't have that same finesse with the forceps, but it still was a rocky road then, even when doctors were doing it super well. When the vacuum extractor is used, very often a deep episiotomy is cut to open up the space to allow that cup to go into place on the baby's head. So those are important things to know if those choices are necessary.
Yeah. And so in addition to those risks that Samsara mentioned, bruising is very common for both of these with baby's head. Tearing of the vagina, perineum, anus, even internal lacerations from forceps that some of these might even require going to the ER for repair.
Yeah.
With forceps, some babies have had temporary paralysis or get temporary paralysis of their face.
Or also back in the day, there were some cases of cerebral palsy linked to the forceps being used, which is one of the reasons why they fell out of favor. But they wait long enough, people forget, and then they bring it back.
Yep. And doctor residents still need to be trained in how to use forceps. So if a resident is recommending forceps to your client, it's a good idea to really to ask questions, to really ask.
How experienced are you with it? Because if it's a choice between the forceps or the vacuum, you want to use the one that the doctor is the most skilled at using.
Yep. Right. So asking really directly how experienced you are with this.
And know that you have the right to ask.
Episiotomies used to be standard practice. So it was like episiotomy and forceps. That was like standard practice for a long time in this country. An episiotomy is a cut to the perineum. So that's skin between the vagina and the anus. And it's either cut straight down or off to the side. It increases the size of the vaginal opening. So that might be for the use of a vacuum. It might be doctor decides to do that. I can't give you great reasons why a doctor might use an
Well,
episiotomy.
one of the reasons that it's not really a good reason is that if doctors don't know how to deliver a breech baby,
Well, yeah, sure, yeah.
So they'll do that to increase the opening for a butt first baby.
Yeah.
But that's not really necessary if they really have breech skills. They can deliver the baby, so the butt sometimes works as well as the head, but they need to know that and have the confidence in doing it.
Yep. Ideally, a local anesthetic is injected before the procedure. What we now know is that episiotomies do not shorten the length of labor. I guess that was a reason that was given, is that it'll shorten the length of pushing, but we now know that's not true. And the incisions become infected more often, and they're more often painful, and are longer than a natural tear. So it is better for your body to tear naturally than to have an episiotomy. If you think about how a body tears naturally, it's kind of like jagged, right? It's almost like puzzle pieces that can then be put back together. That's how your body naturally tore. And so when it's put back together in that way, it's easier for your body to heal the tissues, the nerves, all of that. When you have a slice, you might be a little off, just a little, right? But that kind of not being able to get that same precision can cause more scar tissue and infection and issues with healing, and just a bigger tear. Right. So just being mindful of time, I'm going to keep moving along. But if anyone has any questions that they would, just feel free to say, hey, Mika, I have a question. And I'll stop for that. So cesarean birth is a surgical delivery of the baby through an incision in the abdomen and uterus. It's performed about 30% of women in the US will have C-sections. And they're kind of broken up into 3 categories: planned, unplanned, and emergency. So these are some interesting planned reasons for cesareans that they have here. Like mom is having multiples, which if you're having multiples, you can have a vaginal birth. And it's important to find a provider that supports and is comfortable with your desires. There may be a medical reason for C-section. You might have placenta previa, where the placenta is covering the entrance of the cervix. And also previous cesarean birth. So some people are under the false notion that if you've had one C-section, you have to have C-sections in the future. But for the vast majority of people who've had a C-section, VBACs are possible. Unplanned, I'm actually going to just move to emergency, and then we'll go back to unplanned since they're the most common type. Emergency C-sections are very rare. We hear a lot of people say, oh, I had an emergency C-section, when really they meant they had an unplanned C-section. Emergency C-sections are cases when there is no time for your partner to get into cute scrubs, no time for you to have a conversation about this and come to a decision. Doctors are coming in, they're slapping a mask on your face and wheeling you out to save your life, to save your baby's life. And we are thankful for these C-sections. What is more common is unplanned C-sections. So it could be that it's very common, like abnormal fetal heart rate, labor is just not progressing. They've tried all of their things, let's say in an induction, they've tried all their things to move labor along, and it's just not moving along. Baby moves into a position where vaginal birth is difficult or impossible, but if you have full movement of your body, you're likely to get your baby into an ideal position, or a better position at least. And very rarely, baby's head does not fit into the pelvis. I think sometimes there's a confusion between the position of the baby's head. Maybe the baby's like asynclitic and a bigger part of the head is coming out instead of the smaller part, or the baby's face presenting. And if you're in one of those positions and you can't make a deep squat, let's say, or you can't use movement to your advantage because you're on an epidural, it can be very hard to have a vaginal birth in those cases. So a C-section might be recommended. A C-section, they call it a bikini incision. It's supposed to be below your bikini line, depending on what kind of bikini you wear. Oh, wow, that's all they show there. So a bikini incision, so what they do is they'll cut the fleshy part of the outer layer of your skin. Then they move the abdominal muscles out of the way, so they're not cutting through the abdominal muscles. And then they do another horizontal incision along the uterus. They need to, they'll break the bag of waters and then deliver your baby. Then they'll suture your uterus, bring your muscles back together, and suture your skin, your outer layer. Sometimes I've seen them even use glue on the very outside.
Or staples.
Or staples.
And you have the right to say no to that.
Yep.
You can say you want them to take their time and actually stitch you back up.
Yes. The advantages, C-section births can definitely be life-saving procedures if vaginal birth is unsafe. It is quick, relatively safe procedure. Disadvantages to mother: infection. There's definitely an increased risk of infection. Blood loss, hemorrhage, blood clots in the leg are all concerns. Concerns with future pregnancies, injuries to organs, longer and more painful recovery, and higher risk of emotional trauma or perception of negative birth. For babies, because babies are not getting squeezed through the vaginal canal, which actually squeezes their lungs and allows the amniotic fluid to come out, they're more likely to have breathing problems and more likely needing to go to the warming station right after birth, which also leads to lower APGAR scores, and in rare cases, there are injury of babies. If you are having a C-section, it is important to know that you can ask for immediate skin to skin as long as everything is safe for you and your baby. And most moms can nurse after C-section in the recovery room, so pretty soon after. If for some reason your baby can't be skin to skin with you right away, sometimes people have like serious violent shakes after surgery, which is more than the kind of natural shakes after labor. Are there other reasons why? Maybe you're under general anesthesia if you've had an emergency C-section. It's a good idea for your partner, your support person, to be skin to skin with your baby at that time, so your baby experiences that connection and love. So you can there are ways of reducing the risk of a C-section. Definitely entering labor in good health. So eating, 5-finger eating that we've talked about, exercising, and gentle exercising. Letting labor start on its own and staying at home during early labor. Having that continuous hands-on support from loved ones, from a doula, and using upright labor positions. If you plan on getting an epidural, you want to wait until labor is well established to avoid that chain of interventions, the cascade of medical interventions. And sorry, what it doesn't say here is that most people, I mentioned it earlier, but most people who've had a C-section can have a vaginal birth after a C-section. And you want to make sure that for subsequent pregnancies that you have a provider that supports that, if that's what you want.
Or consider home birth.
Well, those providers, home birth midwives, will definitely support you.
Definitely.
They're included in that.
Definitely. just want to mention it.
Yeah, yeah. My aunt had a home birth after cesarean in the 80s, which was
Yeah,
courageous then.
definitely. This kiddo is so cute. Oh my goodness. Oh my. Change the picture because I'm like my fallopian tubes are twitching somehow.
Oh my goodness.
What a
All
cute-
right. So newborns. It's a good idea. So right after your baby is born, you'll want to do skin to skin, right? And what most hospitals are now recognizing, what midwives and doulas have recognized for a long time, is that first hour after birth is really special and sacred. Usually that first hour after birth, you are still on this like high, this oxytocin, adrenaline high from just having your baby, and you love everyone in the room. It's designed for you to fall in love with your baby. And your baby's awake. And so it's a good time to bond with your baby and to breastfeed for the first time. You don't have to do it in like the first 5 minutes or anything, but like, you know, in that first hour. The first milk is called colostrum. It's a liquid, or liquid gold. It's kind of a golden color, maybe a little bit more watery than looking than mature milk, but it's super potent. You only need little tiny drops of colostrum for your baby. Oh, and here there's a great statistic here that holding your baby skin to skin for 2 hours after birth can increase breastfeeding success by 80%.
Yay.
Really important. Rooming in helps with bonding and breastfeeding. When you're rooming in, it's a good idea to be skin to skin with your baby frequently. Skin to skin, it's so simple, but it is so powerful, and it's exactly what your newborn needs to survive. It helps with breastfeeding. It also helps your baby regulate their breathing. A lot of newborns have to learn how to breathe. They haven't had to breathe before. So sometimes they have these funky breathing patterns, but when they're on your chest, they match their breathing to your breathing. Your chest is also an ideal place to regulate baby's body temperature, and skin to skin helps regulate their blood sugars. So all these very basic things that your baby needs for survival happen best on your chest, skin to skin with you. And if you are taking a sleepy, taking a nap, whatever, need a little space, on your partner, your caregiver, your loved one's chest. And yes, studies show moms and babies get more sleep when they are actually in the same room. When your baby is first born, they excrete what's called meconium. It's not exactly like poop in the same way as we think of poop, but it's like the 9 months of gunk that's been kind of in their system, dead cells, and things like that.
Opening up their little intestines, getting them ready to work. So it's keeping the intestines aren't closing up. It just has it's just that material that settles in there and keeps it open.
Yeah.
So what's also very important about the colostrum, that first liquid gold, is it moves the meconium out of the baby's body. So the baby gets its super nutrition, and as well as that, it primes that whole digestive system of the baby to be able to work for the rest of the baby's life.
Absolutely. And something else I just thought of that you could have a whole 2-hour session on colostrum. But something else that I thought of that I think is really important to mention about colostrum is that one of its functions is the proteins in colostrum. So like a baby's stomach is actually porous. And colostrum, the proteins in colostrum fit perfectly into those little holes in a baby's stomach and seals the stomach gut to prevent infection and reactions to the colostrum. formula has proteins as well, but those proteins do not fit perfectly into those little holes. And so that's why there's an increased risk of infections, especially for preemies. There's a condition called NEC, that they're more likely to get very serious infections that can lead to death from formula being used in those very first days in replacement of colostrum. So meconium changes from, so babies start with meconium, and then as they consume more of your colostrum and breastfeed, the poop has this kind of transitional look to it, kind of like pea soup, maybe a little bit. And then as your mature milk comes in, the poop changes to maybe more of a mustardy color and texture. It might be a little bit grainy. It's typical for your milk to come in between 3 to 5 days postpartum, or your mature milk. It's all milk.
Folks should know that if they've had Pitocin, that might be delayed a little bit, but to not be upset, because the baby's still going to get colostrum, and the colostrum is doing good things. And we're at 8:28. How much time more do we need?
Well, let's let me see. Sorry, how?
Thank you for the time check, Justin.
Yep, thank you very much. So we'll just finish this slide. I'm trying to, we just have 4 more slides, but they're fairly short. We can finish this section if that's okay.
Let's do that.
And then we can
close.
We can close. So babies focus best from 8 to 14 inches away. Actually, really, it's a breast to your face. That's the best way to remember that distance. That's their optimal.
20/20 vision at that distance.
Yes. Babies can recognize scent and taste. They're little mammals. They like the way their parents smell. They love to feel your skin. They love to hear your voice. So on all of these pictures, these babies are really close to their parents. So, your baby's used to being inside of you. So anything other than inside of your body is a little far away from them. So like keeping them as close as possible is really calming and nurturing and loving to them. It's the best place for their well-being. So when a baby cries, you're not spoiling them. It's not spoiling to respond to your baby's needs. That is a way that your baby communicates with you. It communicates maybe that their diaper's wet, they're hungry, there's too much going on, but you most certainly want to respond to baby's cries. And there are a few things that are important to remember about newborns, that their patterns aren't predictable yet, and crying for a total of 2 to 3 hours a day is normal. Like, over, if you counted all of those hours or all of those times up, beyond that, you may want to talk to your provider or whoever's supporting you to see if there are any other issues.
Real quick, let me say that if parents are skin to skin with their little one and they're really paying attention to their little one's cues, it's possible for the baby to hardly ever cry.
Yes.
So bear that in mind. It's very often the cry is the last resort, because the baby's made the little motions and made the little facial expressions and the parent hasn't noticed. So then the baby cries. And then they kind of get on a crying jag and you're trying to calm them. They get very upset. So if you're hanging together, you can prevent a lot of crying.
And there's such a focus on skin to skin immediately after birth, but what we don't necessarily talk about enough in our culture is that skin to skin can go on and should go on for a lot longer than that.
For whole childhood.
Yeah.
You're the one's always going to want your love and your touch.
Yeah. Definitely respond to cries quickly. Never shake your baby. Put your baby to sleep on a flat mattress. And that can be in a bassinet by themselves, as the American Academy of Pediatrics recommends, but you can also create that as a safe sleep environment in your bed with your baby. So there are options for that. And La Leche League has what they call the Safe Sleep 7. So if you're interested in learning more about that, but it's similar to, in terms of the environment, a flat mattress, no loose bedding around your baby's face, but in your bed safely. So ways of reducing the risk of SIDS, breastfeeding is a big protective measure against SIDS. You definitely want to avoid smoking or having even any secondhand smoke or clothing that's had smoke on it away from your baby. That also includes both tobacco and marijuana. And to keep all well baby visits.
You mentioned also it would be a good idea to avoid those harsh, like room scenting,
Yes,
things, the Febreze. Those
absolutely.
things, harsh chemicals can be very hard on little newborn lungs.
Including Dreft, which a lot of people buy to wash their newborns' clothes because it's marketed as a soap for baby clothes, but it's a very harsh smell.
Yep.
And not good for your baby.
Heavy perfumes are really not good. They make us feel good because we want everything scented. Well, sometimes it's the parent that wants to smell. The newborn wants to smell its sweaty parents. That's happiness for the newborn.
Yep. You know, you want to call, so the first recommendation here is if your baby's not latching on or feeding well, and I really recommend get help before it feels like it's before it's a crisis.
Mm-hmm.
Right? Contact your doula, contact your lactation consultant, get that help that you need before you're in a crisis place where now you're going to formula because your baby hasn't fed in a really long time. Let's say.
The doctor's name is spacing. I'm spacing on our favorite breastfeeding doctor's name.
Newman, Dr. Jack Newman.
Dr. Jack Newman. Definitely get a hold of a lactation consultant to get help in real time. But check out Dr. Jack Newman's books. Very sensible and sound advice. Lots of great videos on YouTube that your family could enjoy and get quick information right away that could just change the whole thing, any problems you might have. I've sent clients Dr. Jack's videos and they're like, oh my God, this is a game changer. And things get better for them. So there's lots of good help available.
If we had more time, I had little videos I was going to share with you all, but here we are. Dr. Jack Newman also consulted on a project with the Global Health Media Project, and that has a wonderful series of videos on breastfeeding that I highly recommend. They're 10-minute videos that are great to watch on different topics, like how do you know if your baby's had enough milk, latching, things like that. If your baby frequently needs to be awakened at night to feed, or if your brand newborn sleeps through the night, that's concerning. You want your baby to be able to wake up to feed, and you're going to want to wake up your baby to feed if your baby doesn't wake up on their own. If you have less than 4 yellow stools per day by day 4, or less than 5 wet diapers per day by day 4, ideally you should have a poop diaper and a pee diaper for every day old that your baby's is up to day 7. So 1 poop diaper day 1, 2 on day 2, 3 on day 3 to day 7. After day 7, it can go back down and that's fine. If there's a reddish orange stain in the diaper after day 3, that can be a sign of dehydration. Before that, it can be hormonal or other things.
The reddish or orange stain in the diaper for a female child is important, and it's almost never mentioned. Yeah. And that's just a response to the mother's hormones and the little female soon-to-be reproductive system in 18 years. So don't be scared about that. But there's also a reddish orange crystalline kind of stain, and that is a dehydration. The reddish orange stain that looks like blood is what we're talking about. Bye-bye, Jesselyn. She's got to go. Yeah, so it's important to know those two things. And the dehydration is concerning. Definitely get your healthcare provider. But if you have a little female child and you see that little specks of blood that will look like blood, it can scare parents pretty bad. But it's nothing to be afraid of.
Yep. If the stool pattern suddenly changes, right? They have a lot if they're not producing as many stools, especially, or if it's like more like maybe diarrhea, like if they're not back to birth weight by day 14, usually they'll be checking on you as you go into your appointments. That's where baby's gonna get weighed. Jaundice is a condition that's quite common actually in newborns. It's excess bilirubin, and usually the treatment has to do with sun or UV and lots of breast milk, lots of feeding to get rid of the bilirubin. Sometimes formula is suggested, but that's a situation where you can also maybe talk to a lactation consultant about how you either can have more milk, use more milk, or you can get donor milk to support that. There's more ways than just formula to increase your baby's feeds.
You want to check with medical people. Jaundice can be very, very minimal, and it can be very, very life-threatening. So you want to know how jaundice is the baby, and if it's on the low end, sunshine and breastfeeding, boom, we'll handle it. If it's more than a certain amount, and the doctor can tell you where the line is, if it's more than above that line, then the more invasive kind of hospital treatments are come into play. But you can still breastfeed.
Yeah.
Maybe you might have to be under the lights, but the mom can come and breastfeed in the hospital.
Yep. And if they're not eating at least 8 times in 24 hours, newborns need to eat frequently, every 2 to 3 hours.
Or more.
Or more, absolutely. Okay, well, we have one last section, which is postpartum.
Okay.
We're able to make it to. What would you like to do about that?
So I think a good idea would be, we need to stop now.
Yes.
And we'll reschedule, and we have a couple things lined up in the next week or two. And so we will have you come back, say like in 3 Tuesdays to finish. How's that?
Okay, sounds good. Yeah, let's get it on our schedule.
So there will be a part 3.
All right.
Oh, exciting. There'll be a postpartum section. So
I'll make it a little more beef it up just a little.
It's totally up to you to do that. I'm fine. So I want to thank everybody who's here. We have had visitors. I believe there were 3 folks who are not regular Circle members who were in this class. And we want to welcome them and thank them for being here. This class is one of the things offered by Oakland Better Birth Foundation. Our goal is beautiful births for all our Bay Area babies, and lots of wonderful information for Bay Area birth workers. Thank you for supporting our work. Please have folks come visit our Facebook page and have them like us so they can be kept in the queue on other great things that we're doing. Next week, as Jesselyn reminded me, we're having childbirth ed for not yet pregnant people. So that's going to be lots of fun. I'm looking forward to that. So please feel free to invite friends and family who have not yet had their babies, who are thinking about what it might be like, thinking about, whether that's part of their life goal, whether they want to, have that joyous experience. I will try to be very joyous. Liking the Oakland Better Birth Foundation's page is a way to know about all the wonderful things we're doing. We've got a lot coming up in August, a lot of fun things to look forward to. Please feel free to contribute to our work. You can contribute for this specific class to Mika. Mika, please say your Venmo.
It's at Mika Cade. I'll put it in the chat box too. MIKACADE.
For Venmo, at Venmo. And if you want to contribute to Oakland Better Birth Foundation's work, separate, but it's all the same. You can do that by PayPal at openbetterbirthfoundation@gmail.com. Yep, so if you get to see this on YouTube, be sure to like us, be sure to share the video, be sure to subscribe so you find out more juicy bits from us. I want to thank the beautiful Shipper Circle doulas for being present here tonight. I want to thank Brooke, who is our mommy doula, who was with us tonight, and thank our other attendees who are not in front of my face right now, but I know you're in there. And big thank you to Doula Mika for doing a wonderful job of presenting this information.
Thank you.
Any closing thing you wanted to say, Ms. Mika?
Thank you all for being here. I really appreciate it. And I'm also available for if you have questions or if you would like some additional resources, please reach out to me, doulamika@gmail.com.
The syllabus, can we post the link to the syllabus?
I don't have a link to it.
Is it a Google Doc? Then we could make it.
Yeah, well, that might take a minute because I don't think it's a public link.
So if you would like the syllabus to this class that has further references and teaching helpful stuff, send an email to openbetterbirthfoundation@gmail.com and request it, and we'll get it to you.
Yes.
All right? So a good night to all, and peace and baby blessings.
Bye.
Ciao.
Good night, everyone. Thank you.
Good night.
Thank
Thank
you.
you, God. Thank you, Samsara.
Good night.
Thank
Thank you.
So Priscilla and Anissa, stay with me.
Okay.
No worries.